All right. We've got quite a few people coming in the waiting room from the waiting room. So um, shows about 31 people.
Okay, great.
So we'll allow a little bit of time. Um, but let me say welcome to all of the folks out there. This is Leading the Conversation from NAMI Northern Illinois. My name is Warren Boykin. I am the Program and Outreach Coordinator for NAMI Northern Illinois. NAMI is your, what I like to say, your local mental health organization, your friendly neighborhood mental health organization coming to you from Rockford, Illinois. I don't know where all of our participants are from, but they could be from all over the world, frankly. I'd like to introduce you to our special guest today. It's Eva Zeidner. She is a licensed clinical professional counselor with over 30 years experience working with individuals and families impacted by serious and persistent mental health problems. Just a few words of introduction. Eva earned an MA in counseling psychology at Northwestern University and a BS in secondary education at Indiana University. She is the mother of two young adults, and as a community relations and clinical assessment manager, and formerly as assistant program director of Threshold's Emerging Adults program. Eva built on her prior community mental health experience to assist in the development of services for youth and young adults struggling with serious mental health problems, including first episode psychosis and clinical high risk for psychosis. She's passionate about providing community and professional education related to, related to early recognition and intervention for serious mental health problems and to diminishing stigma around mental health conversations. And without further ado, I'd like to introduce or say hello to Eva. Oh, I'm sorry, a little bit of ado. Um, a little word about our webinar format. We have a question and answer tab at the bottom of your screen if you're using Zoom, and I'll be watching for questions. Eva, is it okay if we hold the questions until the end of the presentation, or how would you like to do that?
I think holding it to the end is probably a good idea. Unless it's something, Warren, that you think needs to be answered in the moment. I'm happy for you to jump in and if it's something where oftentimes it's going to be answered in the next slide or two, that way I can let people know that. We could do
Very
this
good.
informally. I'm usually used to not being in this format where I could see everybody. So um, I'll let you use your
I'm
best judgment on that.
right. Okay, that sounds good. Um, just a little one more word about NAMI. We have a wonderful website, NAMINorthernIllinois.org, and it has a calendar of future events. We've got um, the ability for you to contact us and, of course, become a member of NAMI. You can become a member of NAMI for as little as $5 per year. So we want you to think of it as your community mental health organization. All right. Well, I think that's all of the preliminaries, questions and answers. Um, if you have any thing you want to say, just type it into the Q&A at the bottom of the screen, and I'll turn it over to you, Eva.
Thank you, Warren. Hello, everyone. Thank you for coming today. Our topic is understanding psychosis, recognizing the signs of early symptoms of psychosis, and learning how to address that. What to do if you're noticing this in yourself or a loved one. And without any further hesitation, I want to jump into the presentation because I know we have an hour and there's a lot to cover. As Warren already said, I work in the Emerging Adult program at Thresholds, which is a very large community mental health agency in Illinois. Our program specializes in working with young people who are in the emerging adult developmental phase in life, meaning late teens through mid 20s, which tends to be when most serious mental health problems start, including early psychosis. There are outliers on either side, but this tends to be that the time of life when most people, if they're going to have symptoms, will have them for the very first time. I have been working in this field for many, many years, and during that time, the vast majority of it has been spent working with people who have serious mental health problems, including psychosis. I'm also the mother of two young adults, so I have some street cred in terms of working with young people. Um, the goals today in our workshop are first and foremost to understand what psychosis is. I want to make sure that we're all on the same page because many people misunderstand that term. And that includes people who are very well educated. I've had close friends ask me questions, and I'm oftentimes surprised at the misunderstanding of what psychosis actually is. So we're going to cover that. Then we're going to talk a little bit about the signs and symptoms of early psychosis and of psychosis risk. So individuals who are not yet experiencing symptoms, but are showing signs that they're at risk for that. And we're going to talk a little bit why it's important to intervene early. There's a lot of evidence and research that shows early intervention really matters in terms of long-term outcomes. We're going to consider the best way to approach someone about whom you're concerned, to encourage them to seek help. And we're going to learn about treatment, including the importance of education about one's illness. So, knowing that people who are at risk or who are experiencing early psychosis benefit from understanding what this is just as much as you benefit as someone who cares about them. So let's start with this idea of what is psychosis. First of all, it is a complex medical condition that interferes with the way one's brain interfaces with their experiences with the world. This causes a person to have a loss of contact with reality. So they begin having difficulties distinguishing between what is real and what is not. They're having experiences that feel very real to them that others who know them and who are present at the situation might not be having. So in the illustration to the left on the screen, it talks about the brain and schizophrenia. But I want to make sure that I am distinguishing the fact that we're talking about psychosis as a symptom. It is the primary symptom that we think about when we think about an individual struggling with schizophrenia. But psychosis can be a symptom that's part of many different disorders. We're going to talk a little bit more about that. So when we talk about first episode of psychosis, we talk about people who are having positive symptoms. So if you look at this progression of the illness in front of you, the orange square where it says psychotic symptoms, it says positive symptoms emerge. And when we say positive, we're using the term positive not in meaning something that is good versus bad. We're talking about something that's added on. Namely, we're talking about the symptoms of hallucinations, which are perceptual disturbances that could impact any of the five senses, but primarily we think of people hearing things that others aren't hearing or seeing things that others are not seeing. But it can impact any of the five senses. So I've known individuals, for instance, who have smelled things that others didn't smell, or who indicated that everything that they tasted had the same taste, or perhaps felt things on their skin. So it really could be a hallucination impacting any of the five senses. We're also talking about delusional thoughts. So false or bizarre beliefs that make sense to someone. Oftentimes these things might have a suspicious or paranoid nature, and other people familiar with the situation might say, I'm not having those same experiences, or I'm not sure if what you're saying is actually plausible. We also know that early psychosis causes confused thinking. oftentimes disorganized thoughts that can impact both the way a person receives communication as well as the way they are able to communicate outwardly towards the world, making it difficult for them to articulate things. So this causes difficulty concentrating or understanding people. And overall, this usually leads to a pretty substantial disruption in a person's life, as you might imagine. Psychosis is more common than you think. So 3% of people, 3 out of every 100 people, meet criterion for a psychotic disorder at some point over the course of their lives. And as I was already noting at the beginning of the presentation, 75% of these conditions onset by the age of 24. And this could include things like schizophrenia or disorders on the schizophrenia spectrum, as well as disorders that are part of affective or the mood, such as bipolar disorder or major depression with psychotic features. Risk factors include, frankly, just being young. So we know that most of these disorders, as I just said, start by the age of 24, but between the ages of 12 and 30 are when we're usually concerned. We also know that having a family history of psychosis can increase one's risk, particularly if that is a parent or a sibling, so a very close relative who's had that experience. We know that individuals who have a history of having difficulty making friends, connecting socially, having unusual thoughts or somewhat eccentric behaviors may have a greater risk for these serious symptoms. And there is a growing research base for the role of severe trauma and psychosis. So we talk about something called the stress vulnerability model. And, when we're talking about this, we're saying that there are individuals who have a biological vulnerability. Sometimes we are aware of that vulnerability, perhaps because a parent or a sibling has also had that experience. Sometimes we're not aware of the vulnerability, just like with another medical condition. So, for instance, in some families, cardiac disease might be an issue. And so people might be very aware of the fact that they need to be cautious about their heart health. They might watch what they eat. They might exercise and take care of their blood pressure. In other families, no one has had that kind of an experience, but suddenly you might find out that someone has a serious heart attack. So just like in medical conditions, when we're talking about psychosis, we know that biological vulnerability, sometimes we're aware of, but at other times it can be latent or hidden. But when you add significant stress to that, and when I was talking about trauma, we can think of trauma as a significant stressor. We know that that vulnerability combined with significant stress can lead to a person having the onset of symptoms. And while this is a relatively basic looking equation, it's important to think about this when we're thinking about how to treat and address early psychosis. Because while we do not have control over our biological vulnerability, we do have control over how we react and respond to stress in our lives. And we can work on improving our response to stress. So that tends to be one of the areas when we talk about treatment that we focus on. Understanding stressors and learning how to better respond or navigate around them if we can. So how long do people typically go in the United States without any treatment after experiencing a psychotic episode? Is it 2 months, 10 months, 17 months, or 24 months? I don't know if we can do a little quick poll in the chat. We can try that, or I can just move forward with this answer to this. But I'm wondering how long people think this is, because it seems like these are pretty serious symptoms that would be noticed, correct? I'm just going to move forward. The answer,
Uh, oh,
oh,
sorry. I see a couple of responses here in the question and answer. Most people have answered 24 months. Three people said 20.
well, I'm guessing that the people who are in this group have some experience with knowing that people can go for a very long time. The answer is actually 17 months, so almost a year and a half experiencing hallucinations and delusional thoughts and the substantial disruption to life without any intervention. So why
One
is that?
person, Isabel, did get the answer 17 months. So congratulations, Isabel.
Early
Oh,
experiences of psychosis can be pretty confusing and traumatic, both for a person who's experiencing them and for their family or support network. Oftentimes, people are confused about what's going on. Um, and frequently, this is because in our society, I think there is a very limited understanding of psychosis. It's pretty challenging to know exactly when an episode exactly starts. In fact, it's almost impossible to say exactly when because there's this blurry period where it's just very confusing. But we know that early intervention matters, that we don't want to ignore symptoms of psychosis, and that the longer they persist, the less likely treatment will be effective. So early identification is key. If you see someone or have concerns about that someone might be experiencing positive symptoms, it's important to talk with them to gather information. And if any of you here are familiar with this, you're probably aware how difficult this can be. My suggestion is that you empathize with the distress that a person is feeling, because most people who are experiencing these symptoms, as I said, might have this paranoid or suspicious nature. Oftentimes, they fear that someone is monitoring them or watching them or trying to harm them or others that they care about. We don't want to collude with that. We don't want to agree with the fact that there's a risk. And we also don't want to challenge those beliefs. So, we want to ask them if they are perhaps in need of help, if they're open to getting help. We want to make observations about their behavior and their communication, their personal appearance, especially if we're noticing that they're becoming more and more withdrawn or that their hygiene is falling away. And we want to share this information with potential treatment providers. We want to gauge the degree to which a person is able to rationalize by asking them questions like, I can see how upset or anxious or distressed you are, and I understand that you believe whatever, that someone is watching you, that someone is trying to harm you. Are you open to considering that there might be another explanation for this? Oftentimes, the explanations that an individual might have could be delusional in nature. So they might believe that the FBI is watching them, for instance. If they are capable and open to it, we want to help them come up with alternative explanations. And we want to pay attention to whether this kind of an activity is calming to them or perhaps increasing their agitation. And if it's increasing agitation, we want to move away from that. We want to minimize stress whenever possible. So we want to avoid confrontation. We want to avoid highly emotional exchanges. And we don't want to force social interactions if the person is not open to that. We want to help them avoid loud or bright or overstimulating environments. And we want to discourage substance use whenever possible. And if we are concerned that a person might be at risk of harming themselves or another person, we want to facilitate an assessment by a professional by activating the emergency medical system. If you call 911, ask for a CIT or a crisis intervention trained officer if it's possible, or call your local mobile crisis response team if one is available. Number one, we want to encourage a person to reach out and get help. And if there is a risk of harm, we want to activate the emergency system rather than wait. Coordinated specialty care, or CSC, how I abbreviate it, is an evidence-informed treatment model for first episode of psychosis. And when I say evidence-informed, what I mean by that is that this is a treatment approach that has been studied and found to be something that works in terms of treating first episode of psychosis. This is a treatment model that is actually used internationally right now. And it includes actually this array of different treatment modalities all in one place. So when we talk about coordinating care, we're talking about a group of professionals who can offer things like clinical assessment, medication assessment, and ongoing medication management. Therapeutic interventions like cognitive behavioral therapy for psychosis, support for family members or support systems who are part of an individual's life so that they have education and understanding of what early psychosis is and how to address it. Peer mentoring, which is having someone who has their own personal experience with mental health struggles who can share how they responded and what helped them. Support around employment or education if a person is trying to work or get back to school. Case management or practical assistance with things that an individual might need help with. Things like help with maintaining their benefits, connecting with resources in the community like medical or dental care or food access, and help with housing if necessary. And then community support, which means staff that can go out and meet with a person at their home or the area around their home, as well as in an office. So this is an ideal situation that unfortunately is not available everywhere, to have treatment providers that can provide all of this care in one place. In the state of Illinois, there are programs that are called first.il programs. There are 16 different sites scattered throughout the state of Illinois that can offer services to individuals between the ages of 14 and 40 who have experienced positive symptoms of psychosis for the very first time within the last 18 months. Unfortunately, these programs are not available everywhere. So what should one do? The answer is that we need to think about ways that we can piece together treatment to provide what an individual needs in the best possible manner. So what we're looking for is a way to seek out a combination of both individual and family therapy, coordinating with medication management with a psychiatrist. Sometimes this actually can be found through an ACT team, which is assertive community treatment, or a CST team, which is a community support team, when those teams are available. Oftentimes, staff that are working in community mental health centers providing ACT or CST treatment are familiar with early psychosis. These are usually Medicaid-based programs. So even if an individual has a primary commercial insurance, something that might be helpful is to seek out secondary Medicaid coverage. You also want to utilize support from organizations such as NAMI to increase knowledge and advocacy for a person that you care about. I realize that this is not always easy to do, and I'm happy to consult with people on a one-on-one basis if necessary to help brainstorm how to best do this. We know that detecting symptoms early and then providing assertive or aggressive treatment during this early period leads to improved outcomes for an individual that oftentimes could last over the course of their whole life. And that is why I want to talk a little bit about recognizing individuals who might be at risk for psychosis before those positive symptoms actually start. So you recognize that this is the same slide that I showed earlier, where we were talking about the box that says psychotic symptoms. So these symptoms of hallucinations, delusions, confused thinking. You'll notice that in this slide, I've highlighted this square that's one earlier where I say clinical high risk for psychosis. So we start out with this idea of the vulnerability. Vulnerability is where there might be risk that we're familiar with, or it might be hidden or latent. At the very start of this risk phase, negative symptoms emerge. And then later on, something called attenuated symptoms emerge. So what we want to do is get a better understanding of what I mean by both negative and attenuated symptoms. Negative symptoms of psychosis, again, negative is not used as a term meaning bad, but instead it's meaning a lack of or a decline in the following. Things like motivation or volition for daily activities. A lack of energy and enjoyment in things that a person formerly enjoyed. Difficulty focusing or concentrating one's attention. A decline in the actual amount of words that a person says. So literally, a person might talk less. Their emotions might seem flattened out or blunted, and they might socialize less. So spend more and more time alone and less time with friends and family. Now, the thing about negative symptoms of psychosis is that they pretty much mirror serious symptoms of depression. Psychosis and the negative symptoms are not exactly the same as depression. But if a person has never had active symptoms of psychosis before, the negative symptoms of psychosis could very easily be confused with depression. And a person might be receiving treatment for depression, which essentially means that when a person is having serious symptoms of depression, we want to consider the possibility that they're at risk for psychosis. Doesn't mean that every person who has serious depression is going to experience psychosis, but simply that these negative symptoms mirror depression in a very similar way. So it can be very confusing. The word attenuated, which wasn't really part of my daily vocabulary until I started learning about psychosis risk, simply means reduced in force, effect, or value. So we know that positive symptoms of psychosis are hallucinations, delusions, and confused thinking. If we're thinking about those kinds of symptoms reduced in force, effect, or value, what are we looking at? We're talking about symptoms that could be unusual thoughts, sensory experiences, or perceptual changes, but individuals experiencing these things are able to still discern reality from their experiences. So for instance, a person might see shadows. They might think that there's something hovering behind them. Every time they turn, there's nothing there. And they might feel confused by this and a bit concerned by it. They might, for instance, hear their name being called or hear banging or knocking or hissing sounds. They might begin to experience increased sensitivity to light or to loud noise. And they attribute these things to their mind playing tricks on them. They are things that are causing them concern, but they're not yet thinking that someone is actually speaking to them or calling their name. They're more or less thinking like, wow, it's weird that I kind of keep getting confused, like hearing someone calling me when no one's there. In the DSM-5, there is a syndrome called attenuated psychosis syndrome. It is grouped under the F28 diagnosis, which is other specified schizophrenia spectrum and other psychotic disorders. And it's considered a condition for future study, but it is diagnosable. Some things that are really important to consider Um, because we don't want to pathologize. I mean, all of us occasionally think we hear someone calling our name, or occasionally we think we see something and then it's not there. So every time that happens, that doesn't mean that you're at risk for psychosis. We're looking, when we're talking about attenuated symptoms, at things that are new or worsening, usually something that started or worsened within the last year. We're looking for things that are happening at least weekly in the last month. So if it just happens once or twice, that's probably not concerning. But if it's happening regularly, at least once a week, we're also thinking about things that are not better accounted for by another diagnosis. So the example that I oftentimes like to use is if someone has experienced something very traumatic and is meets criterion, say, for post-traumatic stress disorder. Let's say that this individual, when they were riding public transportation home from work at night, experienced an attempted mugging. And every time when they are in that situation where they are returning home from work at night, they are feeling this heightened sense of anxiety. And sometimes they feel like there are people around them. They might even think that they're hearing someone calling them, or they might feel that they're hearing loud sounds. In that situation, I would say that those symptoms are more related to their recent trauma. Now, if that situation starts to generalize and they start thinking that they are hearing sounds or feeling this kind of anxiety and presence around them, when they're not in the same kind of situation where they were put in harm's way, say it's happening when they're in the safety of their own home or their own bedroom, then we might start to consider that this could be psychosis risk. Because that's the kind of trauma or traumatic experience that could potentially lead to that. But I would say, particularly if it's happening in the situation where the traumatic experience occurred, we probably wouldn't consider it that. We would consider it part of the trauma reaction. Also, when these things happen, we want to know that they are causing an individual distress or somehow interfering with their functioning. I have met with individuals who've told me like, oh, I've always been like this. This has been happening to me my whole life. It doesn't particularly bother me. Well, that's not necessarily psychosis risk then. It's usually new or worsening and causing distress. We also want to know that these are things that are happening when an individual is not under the influence of a mind-altering substance. So we have to consider the impact of substance use on a person's condition. And we are going to talk a little bit more about substance use and the risks that substance use can cause. But usually with psychosis risk, it's not just when a person is under the influence. And we also want to consider that this is something that is not happening only right before you fall asleep or just after you woke up, because your mind is still in an altered state of consciousness during that time. So we would want it to also be something that happened, during waking hours. It's important to also take culture and life circumstance into consideration to determine if a symptom is really more of an appropriate response based on that individual's life experiences. So, for instance, some cultures have very highly spiritual beliefs. I have worked with people who, for instance, believed that, loved ones' spirits were still walking the earth for a period of time after death, that they needed to be laid to rest. That is more of a cultural belief versus a psychotic type of symptom. So that's the kind of, we even want to take into consideration if a person grew up in an area where they are at risk more of community violence, for instance, they might have a heightened sense of awareness when they're in the community. That again would not be the same kind of thing as someone who is just feeling hyper alert and hyper aware and feeling that there's a presence around them. So these are really important things to take into consideration. Let's talk a little bit more in detail about what those clinical, those attenuated symptoms are going to look like. Clinical high risk is a term that is used simultaneously sort of with attenuated psychosis syndrome, which is the actual diagnostic term. So when I say clinical high risk, that's what we're talking about, this phase where a person is having attenuated symptoms prior to having active symptoms. We know that there are mood changes. So oftentimes the person might seem like they are increasingly depressed or anxious. They might have that lack of energy, remember the negative symptoms, and they might not be able to enjoy things that they formerly enjoyed. Together, these things are happening with a drop in functioning that's impacting their daily life. So it's something that's noticeable. We also know that there are behavioral changes, including social withdrawal, decreased attention to hygiene and personal appearance, paired with an impact in their functioning. Oftentimes, when a person is experiencing early psychosis, you notice that their hygiene totally falls off, where they might not be able to, they don't bathe, say for maybe days or weeks at a time. In this situation, we're looking at something that's a little bit, lower than that. So, for instance, a person who formerly dressed in outfits is now wearing kind of sweats every day. They're paying less attention to their overall personal appearance than they normally do. We also know that there's a cognitive decline causing a person to have difficulty with concentration, with memory, and completing tasks. And then this leads to problems with their work and school functioning. So oftentimes, having difficulty completing tasks at work or having a decline in their grades or performance at school. We know that a person has these unusual sensory experiences or perceptual changes, and that they're questioning the reality of these experiences. So that line between what's real and what isn't gets blurry. They're still able to discern what's real, but sometimes they start to question that. So again, the attenuated symptoms look like seeing shadows, hearing knocking or banging sounds, or barely audible conversations. So sometimes people will say that they hear like whispering, but they can't really tell what a person is saying. I've had young people tell me that they walked over to a window to see if people were outside talking because they heard this like barely audible conversation. I've also had people say things like, my mom left for work and then I went to take a shower and I could hear her calling me, yet I knew she wasn't even in the house anymore. And so I was really kind of freaked out by that. We also know that people oftentimes have sensitivity to sound, bright, loud sounds or bright lights. And that can, for instance, make it difficult if you think about what it's like in a typical passing period in a high school, for instance. So that might make a person avoid going to school or ditch classes. Usually people are still attributing these things to their mind playing tricks on them, and they can still discern reality from fantasy. That's the key point. We also know that there's increased suspicion, paranoia, or grandiose ideas. Again, a subacute level from what we would see in active psychosis, yet something that's noticeable. So I have had parents share with me once their child was diagnosed with psychosis, things that happened a year or two earlier. For instance, there was a mom who told me a story about going on a shopping excursion with her two daughters and her mother. So it was basically, sisters, their mom, and their grandmother. And the young woman who later was diagnosed with psychosis was fairly insistent that her family was poking fun at her, kind of making fun of her, not understanding her. And they didn't understand what was going on. They just thought that this was kind of bizarre. But we know that that kind of feeling that others are out to get us or not understanding us oftentimes is what people are experiencing during this risk phase. So a young person might begin to pull away from friendships and explain this as like, well, I just don't really feel like they've got my back. I don't really feel like I could trust them anymore. And while we need to definitely take into consideration that sometimes changing friend groups is something that's part of adolescence or young adulthood, that this potentially could be a sign of risk, particularly if we pair it with these other types of symptoms that I'm talking about, and if multiple things are happening all at once. We know that there's that biological connection. So having a first-degree relative, that means a parent or a sibling who's diagnosed with a psychotic disorder, increases the risk of psychosis from 3% in the general population to 10%. Doesn't mean that everyone who has a family member who's experienced psychosis is going to experience it, but it means that there's this slightly higher risk. It's important to know that of individuals who meet criterion for this attenuated psychosis syndrome or this clinical high risk, not everyone develops psychosis. In fact, what we have found is that 1 out of 4 people who meet criterion actually transition to having positive symptoms. We just don't know who they are. So at Thresholds in our emerging adult program, we had a 4-year grant from SAMHSA, which is the Substance Abuse and Mental Health Administration, that's part of the federal government, to design clinical services for people who were in this risk phase. A lot of research has been done in this area, but very little clinical treatment was actually provided. So Thresholds was one of 22 sites in the country who developed clinical services for people in this risk phase. We worked closely with the other 21 sites in the country, and at the beginning of our 4-year grant, the statistic had been that 1 out of 3 people were developing active psychosis. 1 out of 3 people who met criterion for this clinical high risk phase state. At the end of the 4 years, that had turned from 1 out of 3 to 1 out of 4. So we knew that something we were doing in our treatment was effective. It's just always hard to say exactly what. What we offered in treatment was actually nothing that would ever provide any harm. And so what I want to talk about is, what did that treatment look like? So if there is someone in your life that you're concerned about, you can advocate for them to get this kind of care that will improve their chances. Something else of note that's important is that individuals who have formerly had symptoms of psychosis, positive symptoms, meaning full hallucinations or delusions, who are experiencing some of these attenuated symptoms. We don't use the term clinical high risk for psychosis. We don't use attenuated psychosis syndrome, but we say that these people are at risk of having a relapse. And so we definitely want to get them back to their treatment provider and make sure that they are taking medication and addressing these symptoms, because they are signs of a risk of relapse. But we don't use these terms. The terms clinical high risk for psychosis and attenuated psychosis syndrome are reserved for individuals who have not ever had positive symptoms. So we don't know exactly how and why psychosis occurs, but we do know that symptoms of psychosis are treatable and that recovery is possible. And we know that psychosocial interventions paired with a more medical or biopsychosocial approach can be very, very effective. So medication paired with treatment that reduces stress and stimulation and teaches coping strategies both to a young person and to their family or support system can be effective. So we're trying to intervene early to decrease the severity and frequency of symptoms, to hopefully decrease or even prevent the need for hospitalizations, improve a person's school and work participation, and overall, hopefully improve their overall quality of life. If there's someone who you have concerns about, what is the first thing you should think about doing? We want to assess for symptoms by both observing and by asking questions. The reason I say observing is because there are a lot of things about an individual who's starting to have suspicious or even a little bit paranoid thoughts that if you ask too many questions about those things, you're just kind of feeding that. So there's a lot that we could gather by observing. We can ask someone if they ever feel like their mind plays tricks on them. Even if in a situation, if someone asks something unusual of you, you might say, like, do you feel like maybe your mind could be playing tricks on you? And just see how they respond to that. We could ask if they hear or see or feel things that potentially aren't really there. Sometimes this, again, is something that we're observing. Sometimes we can actually ask a person and they respond. If you ask someone if they're suspicious of others, that's probably going to make them more suspicious, but we can usually deduce that based on an individual's behavior and the things that they are saying to us. We also can sometimes ask if a person feels like they're not in control of their own thoughts. If they wonder if what they're hearing or seeing is real or imaginary, if they're feeling like there's a blurriness that they're starting to experience, whether or not they're feeling disconnected from others, if you're noticing that they're spending more and more time alone, to ask a little bit more about what's going on, to ask if they're having difficulty concentrating. They might experience frustration because they're having difficulty focusing and therefore are not able to do their schoolwork. So it's this combination of engaging an individual in conversation and also making observations and deductions based on what we can already see is happening. If we're noticing that these things are going on, how on earth do you address this to a person? Because this is a pretty sensitive topic, right? It's a hard thing to approach. First of all, it's very important that if we're going to talk about it, that we make sure that an individual is aware that we are not saying that they are going to develop more serious symptoms, but just that we have concerns that they could be at risk for something more serious happening, and that we know that getting help can be very, very effective. For most people, symptoms go away. For some people, they kind of stay the same and people learn how to manage them. And for 1 out of 4 people, they potentially could get worse. We want to make sure that individuals and their families and support system know that they are not to blame in any way. They did not cause the problem. We want to reinforce the idea that early intervention can help prevent symptoms from getting worse. So don't wait, get help now. And we want to make sure that they understand that they're not alone, that this is something that is, it occurs, that there's a reason why it is an area of study and treatment, and that getting help is something that will make a difference in their life. So being overall supportive and empathic to their condition. During this risk state, treatment goals number 1 are to prevent the psychosis condition onset. We want to improve functioning and decrease symptoms among people who do not develop psychosis by providing therapy to address underlying stressors in a person's life, education about what psychosis is to clarify this and to eliminate faulty beliefs that a person might have, and medication when warranted. This does not necessarily mean antipsychotic medication. Sometimes antidepressants or anti-anxiety or other medications can be beneficial in addressing symptoms and then preventing things from getting worse. And for people who do develop positive symptoms of psychosis, we want to reduce that period of time. Right now, like I said, it's about a year and a half in our country that people go with no treatment. We know that by reducing that period of time, we could potentially reduce the severity and frequency of symptoms, improve participation at school and work, and overall improve a person's quality of life. So acting quickly is very, very important. The most basic recommendations are important, starting with this idea of taking care of one's health. Good nutrition, regular sleep, and exercise are very, very important. Much of the time, people have difficulty sleeping and can potentially exacerbate symptoms by not sleeping enough, which might be one of the reasons even to get them to their primary care physician to have a conversation about why they're having difficulty. We also know, as I noted earlier, that stress plays a significant role. So decreasing stress, sometimes by lowering expectations, even temporarily at school, by getting accommodations or reducing a work schedule, avoiding substance use whenever possible, and practicing mindfulness, which is that ability to be present in the given moment. Oftentimes, this can be done through skills that are taught in counseling, also through meditation, if a person is willing to try that. Oftentimes, these are a practice that a person has to slowly start. That can be combined with exercise too. Things like yoga oftentimes helps people practice mindfulness. We really want to encourage someone to seek mental health treatment. We want to look for providers who can do things like help a person identify stressors in their life and learn how to reduce these stressors by teaching resilience and coping skills and learning how to address stress triggers. One of the things about stress identification that I think is important to pay attention to is that a lot of people are not very good at recognizing stress when it's happening. And I think that people who are at risk of psychosis oftentimes are particularly not good at recognizing this. I mean, I've met with so many people over the course of the last, 25, 30 years who will tell me circumstances in their life that sound to me like the perfect storm, like horrible things happening. And then they try to brush it off as, no, it's really not a big deal. I'm fine. I'm not worried about it. And so I think culturally, our culture tends to encourage us to believe that we should be able to multitask and handle difficult situations with a kind of stoic attitude. So this idea of just learning how to express one's emotions, to recognize stressors, can be a really key part of therapy. There is a manualized treatment that's called Individual Resiliency Training, or IRT, that is available at this link. IRT was designed to work with people who've had a first episode of psychosis. And many of the approaches in this manual can be very helpful to address both clinical high risk for psychosis and early psychosis. And so this is actually a link to the manual itself. We also know that having an assessment to see if medication is warranted and to provide recommendations and ongoing support around medication use can be really, really important. Addressing substance use, educating about the risks that substance use pose for these more significant and serious mental health problems like psychosis is really, really important, particularly cannabis risk, because since cannabis has been legalized, we know that there are an increased correlation between people who are using marijuana and people having first episodes of psychosis. I'm going to talk, I have a couple slides specific about marijuana use that we're going to address that. It's very important to use motivational interviewing, which is really just a therapeutic approach that involves asking questions so that a person can come to their own conclusion that perhaps they should try to reduce their substance use or maybe even eliminate it. People tend to not always respond when we tell them what to do. Most of the time, they're aware of the fact that perhaps they should use less, but we want to help them learn to use more safely and overall reduce use over time. And we want to
Eva,
provide education about psychosis. Was there
Eva,
a
if you don't mind
question?
my interrupting, I know we're getting close to the 1 o'clock hour. We got about 3 minutes to go, and we have just a couple of open questions. Um, would it be okay if I just pose those really quickly?
Sure.
Okay, the first
I'm thinking, how
question,
many slides do I have left? I have a couple slides left. So yeah.
I figured you were getting close to the end. Um, I'll just interrupt with this one question, and then we'll come get the last one afterwards. It says, "Why apply for secondary Medicaid? Does private insurance not cover?"
So the there are a couple of reasons. Um, when a person is experiencing a psychotic disorder, um, oftentimes treatment that is provided through the public sector might be more oriented towards treating those serious disorders. Not to say that there are not private practitioners, but treatment approaches like the two that I noted, an assertive community treatment team or a community support team, could be very, very beneficial, and they are not usually covered by commercial insurance. It's something that there's a lot of there's legislation and advocacy working towards that, but all commercial payers still are not covering those treatment approaches, and they are covered by Medicaid. So they would be usually rejected by the commercial insurance, and then the secondary insurance would pick that up. The other
Interesting.
reason why I say that this is important is that oftentimes a person requires acute care, sometimes in the hospital and just sometimes even out of the hospital, multiple sessions a week that can become very costly. And so most commercial plans require that a person pay a coinsurance and a copay, and coinsurance can be picked up by a secondary plan like Medicaid, therefore oftentimes making a person more likely to stick with treatment because they're not as worried about the overall cost of this treatment. And so that's why I recommend that. While it's
Yeah.
available and we can still get it, I always encourage people to apply for secondary Medicaid.
All right. And since we're getting close to the end of time, I want to respect people's time commitment. There were two other questions that had come up. The first one was, were there CEUs offered? Now, I know that it wasn't on the website announcing this, but it is such a thorough presentation. We were just wondering if you've ever given this presentation and offered CEUs for it.
I am not offering CEUs today. I didn't know if NAMI wanted to. This was actually, we're doing two of these, and this one was supposedly oriented towards consumers. So I think we really didn't talk about it at all. In 2 weeks, I'm doing another presentation that's very similar but slightly different, that's oriented towards treatment providers. And I don't know if it's something that that NAMI would want to support, but it's something maybe that we could talk about.
Wonderful. And the last question is kind of similar. It says, do you, Eva, provide consultation to therapists? Are there more resources or trainings and webinar that NAMI offers for therapists and professionals? That's exactly what you just mentioned in 2 weeks. That's
So
going to
in
come
two
up.
weeks, I mean, it will be a very similar presentation with a couple of additional things, including kind of how we diagnose people with clinical high risk, And at the end of this presentation, I do have a couple of slides. I'm sorry, you guys.
Okay.
I can send a PDF of the slides that can be shared. So this was psychoeducation, a little bit about CBT, the
Hmm.
cannabis use, and then the last, what you can do. And then I have a lot of links of resources here.
Wonderful. That
So I am
answers.
happy to share this because I know people are usually interested in doing additional reading.
Mhm.
And I think that that probably is the best way for us to do this, right? If I send you a PDF
Absolutely.
of this, you can share it with participants.
Right. That is the question that Jody Green had, Guru had posed. One last question. Um, it says, is TMS therapy recommended for treatment of psychosis?
You know, I have to apologize. TMS, I'm not even sure. I think it,
TMS is transcranial magnetic stimulation.
yeah, I don't know a ton about that. I think that there have been some clients in our program that have tried it when they've had particularly resistant, but I really can't speak to that.
Okay.
The evidence-based practice is cognitive behavioral therapy for psychosis, which is a combination of CBT and a lot of education on psychosis. So, just to kind of wrap things up, a lot of what I like the things that I have mentioned today in this presentation, those are the essence of the education. This idea of, how we recognize and respond to stress, um, recognizing that the earlier we address this, oftentimes the easier it is. Individuals, certain percentage of individuals who experience psychosis develop an inability to recognize that they're experiencing symptoms. It's called anosognosia. It's the same symptom that's present in people who have dementia.
Right.
And the earlier we can teach people about psychosis, so when they still have this ability to discern reality, oftentimes we can present this as this is a medical condition. This is something that you did not cause, to help people like internalize more of these beliefs and understanding of the medical condition, and therefore be as much as possible ward off this possibility of anosognosia. But we know that a certain percentage of people do experience that. So understanding and addressing psychosis assertively in a non-frightening way, in a matter-of-fact way, I think is very important. Whether you're talking to family members, loved ones, or clients. And so, doing things like ruling out medical problems and substance use, asking these questions, getting consultation. If people call me on I am happy to talk with them and help provide direction. Unfortunately, my program is limited geographically to where we serve. Um, but I think part of all of this, as I say on this last slide, is fighting against mental health stigma. One of the reasons that many people don't seek treatment is due to this idea that, like, I don't want to be called crazy. I don't want to, and that's not my words. That's what oftentimes people say to me. And so the more we can talk about this in a matter of fact way, I think the more likely we are to help people be more open to receiving care.
I think that's a great note to finish on. You mentioned your geographic area. Where are you located, Eva?
So I have teams on the north side of Chicago and the west side of Chicago. So we serve Western Cook County and part of the west side, and then the whole north side of Chicago. Um,
Hmm.
we do, because of the fact that we're doing outreach, going out to people's homes, we have limitations. And there was a period of time where we were saying we would work with people no matter where they lived. The reality is that many times when people are experiencing these symptoms, they come to a point where they decide, like, I'm not doing this. You all have a problem, it's not my problem. And so we really feel that going to them allows us to re-engage them and keep them in treatment when otherwise they might have fallen away.
Wonderful.
And so we've limited our geographic, areas because
Perfect.
that way we can provide outreach. And Thresholds is an agency known for doing outreach.
Well, I have the questions here. Um, I think you've addressed most of them. The only one, I don't know if you have your contact information in your PowerPoint presentation, but I know that you're going to be back in a couple of weeks.
I do, and I'm going to get to it here. Here it
All
is.
right. Oh, wonderful. And also, there was a comment that I think is very appropriate. Michelle Knight mentions contact the Rockford NAMI office to reach out for additional support. Michelle comments that she's been navigating the VA and private medical sector alone for her son and really needs some guidance with negative psychosis symptoms. And we have two mental health advocates on staff, and I really appreciate your time, Eva. Thank you all who have participated. This was very well attended, and we will have the recording of this session on NAMI Northern Illinois' YouTube page. So if you go to YouTube and search for NAMI Northern Illinois, we have a page with the recording of all of our previous webinars, and this one will be posted probably by tomorrow, and we will have links to your PowerPoint presentation there.
Great. Yeah. Links to the PDF, please. Yeah.
That's what I meant, the
Yeah.
PDF.
I
Got it.
will send that over to you. Thank
Right.
you all for coming. I wish I could see everyone, but I hope I will either need to cut some slides or talk faster.
Well,
This is a pretty meaty topic to address in an hour.
right. It's really appreciated, and it obviously is something that is pertinent and very pressing in our society. And I'm so glad that it's a two-parter. So we'll see you in a couple of weeks, and thank you again. Thank all of you for participating and leading the conversation.
Have a good
Have-
day, everyone. Thanks.
You too. Bye-bye.